Good afternoon, everyone. iTech India welcomes all the participants for today's NDLS session. Today's topic is scaling up services at LAC and LAC Plus centers, and the speaker is Dr. B. Ravi Kumar. Dr. B. Ravi Kumar, sir, is a public health specialist and is currently working with iTech India, supporting the care, support, and treatment division at NACO. We now request Dr. Bhavani Singh Kushwaha, sir, Deputy Director, CST NACO, for opening remarks.
Thank you, ma'am. Good afternoon, everyone. This is a very pertinent topic for today's NDLS session on scaling up services at LAC and LAC Plus centers. And I'm sure Dr. B. Ravi Kumarji will take on a wonderful session. As we all know that LAC and LAC Plus centers are essential for providing patient-centric care under National AIDS Control Program. And this is very important to improve the access to ART treatment, and especially in remote area. And what happens, these centers promote treatment adherence by addressing barriers such as frequent visit to ART center is not required, especially in cases where distances are very much and there's a lot of out-of-pocket expenditure on the travel that is being reduced, and it also in an indirect way help in the adherence. And we know that since the introduction of Treat All policy in 2017, the scope of LAC centers have expanded to include ART initiation also. We are also exploring the telemedicine ways to initiate the clients in far-off areas at these LACs. And this also make treatment more accessible, bridging the gap between HIV testing and treatment. Initially, there were LACs established at the ICTCs only, but now in the community setting also we are exploring, and apart from it at the OST centers where IDUs are there and their adherence is a bit compromised because they don't want to go to many centers simultaneously, but they are coming to OST centers regularly. So there also we are trying to operationalize LACs wherever possible. For inmates in the prison, we are thinking of LACs, and it has been started in a couple of states. And so at the TI in the community setting, as I said, currently we have 1,261 LACs and LAC Plus centers, which support around 125,000 PLHIVs, helping in their treatment adherence and retention. And this truly this is a true way we are implementing our differentiated service delivery model under NACP to effectively meet the diverse need of the PLHIVs. And I'm sure this is very helpful model of implementation for our PLHIVs. And in future also, we want to expand our LACP, LACs and LAC Plus centers, but without compromising on the quality of services being delivered. So that aspect also, I'm sure Dr. Ravi will touch upon today, that it's not just the numbers we want to increase and mushroom of the LACs, but how the quality need to be maintained, and the training aspect and regular monitoring and handholding should be integral part of the activity. So thank you everyone for joining, and I'm sure that Dr. Ravi will take a wonderful session, and looking forward to your questions. I and my team from NACO will be here to gather the observations you all will be having. So thank you everyone, and have a good session today. Thank you.
Thank you so much, sir, for your support, your time, and for setting the tone. All the participants are requested to please place their questions in the chat box. We'll be taking up questions at the end of the session. I now request Dr. Ravi Kumar, sir, to please start the session.
Yeah, thank you. Thank you so much, sir. Dr. Bon, sir, good afternoon, and thank you for giving the opportunity to take the NDLS session. Thanks for Dr. Purnima and for all the participants for taking out their time and attending this session. So I'll just go into the session and hope no, you can post your questions in the chat box, and finally we'll take the questions for the and give you the answers. So to start up with the session, we all know that no, why exclusively the ART and ART centers? No, and we now talk about the LAC and LAC plus centers. I'm sorry about that. The LAC and LAC plus centers. So the basic objectives are no, why the LAC and LAC plus centers were no started, and know how the scale up has happened. We look at the in the background part of it, what exactly the objectives and functions of the LAC and LAC plus centers. We all know that the basic things about LAC and LAC plus centers, but as the time moved upon, right from the rollout of ART way back in 2004 and the establishment of the ART centers, the functions have been revised no over the time progressed, and the scale up has happened. So there are certain functions which we specifically discuss in this particular session, and the process of linking in and linking out from the nodal ART to the link ART centers, and from the link ART centers back again to the nodal ART centers. What are the situations that we have to transfer, link out the patients, and what are the major activities by the nodal ART center when we talk about the support that needs to be given by the nodal ART centers to the LAC and LS plus centers. So how do we actually monitor and mentor them on what frequency that we have to do it? And Dr. Bonser clearly told that no, the importance of nodal ART centers in providing the necessary support for the link ART and LAC plus centers. And how do we actually initiate the ART or the LAC plus centers, as this is a new concept of the LAC plus centers after the revision of the guidelines, and before that, after the TTOL policy has come into the picture. So what are the criteria that needs to be kept in mind when we talk about the SOP for the ART initiation in LAC plus centers exclusively, not at the LAC centers, and what the recording and reporting needs to be maintained, what annexes need to be followed from the revised 2021 ART guidelines. And we do also discuss about, as Dr. Tony sir was saying, that the LAC, the ART initiations have been scaled up till the level of the OST centers to ensure that the adherence has to be there for all community people also. So the concept of the community ART refill has come into the picture, and we also discuss more about how the community ART refill groups. So what do you mean by that? How they are to be formed? And what are the roles and responsibilities of the community ART refill groups members in that? So we all look into all this in this particular session. To start up with exactly what's the background has been. So LACs were initially established way back in 2008. So we all know that the ART program has started in India way back in 2004. Now we are in the 20th year of the ART program in India. And after the ART centers have been established and rolled out, 2008, there was this discussion about how do we actually distribute the drugs for the people who actually come from the far off places. Then the concept the LACs were established in 2008, and also to ensure that the linkage laws between the ICTs and ART services was there. So how do we actually address these particular the linkage laws? And there also a study commissioned by NACO which has reflected, and the reasons for the gaps have been found that the PLH being asymptomatic at the time of detection, and due to the long distance and the financial issues, they may not be able to come to the nodal ART centers in particular time during those days. I'm talking about not the before the TTOL policy has been rolled out. And then the need for multiple visits for the baseline investigations. We all know that when compared to almost like 700 odd ART centers, we have more almost near to 5,000 ICTC centers. So the people being detected at these centers and needs to be linked to the ART center. So definitely there will be a linkage loss between the testing, diagnosis, and linking back the treatment, and the need that they have to make multiple visits to undergo multiple things like baseline investigations. Then you come back again for collecting the reports. Then you come and then see on a different day. So there were certain factors which were hampering the linkage loss between the ICTs and the ART services. To address all these centers were established. And when we looked at the data presenting at the national level, nearly 20% of the patients reach at a very late stage. That means where the CD4 count has below 100, where the risk of the mortality is higher, more than 2 to 3 times. So when you talk about the CD4 count less than 200, you are always prone for more OIs. So by the time they always present not at a very late stage. So the scope and functions of the link ART centers were expanded to include the pre-ART care way back in 2011. And then also the another model that has come up during that time was upgrading these link ART centers to the LAC plus centers, where you have a designated staff nurse as no the representative from the SACS from the ART program being there and providing the necessary services. So when the treat all policy was rolled out in 27, and we all know that irrespective of the CD4 count, the PLHV needs to be initiated in ART. So once that has been rolled out, so the LAC plus function has been, the scope of the function has been expanded to include the ART initiations. So LAC plus centers will also be authorized to initiate after written approval from NACO and SACS, and there are certain criteria that needs to be followed, which we'll discuss in the coming slide. So there's a bit brief background way back how the centers have started, how they have been scaled up LAC plus centers, and now what are the revised functions now that we look at the LAC plus centers. So we all know that the centers were actually formed. Just a second, give me a second. So if you look at the functions of the LS and LSC plus centers, we all know that these centers have been established to increase the access to the ART or bring home the services of the ART services near to the home of the PLHIV. And by doing that, you always look at improving the drug adherence, the retention of the long-term retention of the PLHIV. And as we discussed about the linkage loss, so how do you decrease the gap between the testing and the treatment services for the HIV? And we integrate, how do we integrate the HIV care support and treatment service within the general health systems? When we talk about the district hospital, the area hospitals, and below that level, the PHCs and CSCs, and we talk about in other parts of the state, like the taluk hospitals and sub-district hospitals, those will be there. So how do we actually integrate those services in the general health system? By providing access to the testing and treatment within the same place. So I don't need to refer a patient, no testing, you get the testing done here, and then once you confirm, you go for a confirmation positive to another center, and you get the confirmation done there, and then you move to another center for the ART initiation. So decrease all these to integrate the within the general health systems with the testing and the treatment services within the same facility, and which leads to the involvement of the community in the retention of the PLHIV. So what are the activities and the responsible persons? Sorry about that, just a bit of slide here and there. So what are the minimum requirement that needs to be taken up for the setting up an LAC and LAC plus centers? So we just look into what needs to be done. So when we say identification has to be done, so this identification has to be done by the SACS in coordination with the DAPQ and DISHA. So a justification has to be given why I need to set up an LAC, LAC plus center. What is the need for me to identify this particular place? So you have to give a justification saying that the number of the testings that are being done at that particular LAC or LAC plus center, the number of positive being detected during a particular period, maybe 3 to 5 years of period. And then you also have to give a justification that how many people are accessing right now at that particular LAC plus centers. So all these criteria has to be taken into picture. A team has to be formed, and then they visit those centers and then submit that for the administrative approval in the annual action plan of that, but we'll again send it for the higher approvals for the NACO level. So who all has to be there at that particular, sorry, Kiran, the internet connection is saying the unstable. Am I audible?
So you're audible. I'll share the slides from my end. Is that okay?
No, the connection is unstable.
You're audible, sir.
The connection is a bit unstable. Yeah, fine. So these administrative approvals have to be taken at the state level, and then further the administrative approvals from the SACS have to be sent to the NACO for the further approvals from NACO. So the activity should be taken up at that level is the meeting between SACS and DAPCO, and then particular hospital authorities where you are going to set up an LAC or LAC plus center. And then as I told you that the feasibility assessment report, which is there in the Annexure 8 of the operational guidelines, has to be filled up. And then the concerned SACS, the in charge and the district hospital medical officer or the RC or the technical expert of that particular state has to be in the team. And then there has to be an approval letter to set up an LAC subject to satisfactory feasibility report. So SACS with information to NACO will be done. So these are all some of those steps which needs to be taken up. And then once the approval has been given by NACO to set up the particular LAC or LAC plus centers, then the trainings have to be planned at the designated training centers, or usually if it is done at the state level, as we can do it at no the particular nodal ART center. If the number is high, then a center level trainings can be planned, a 2-day hands-on session for the LAC team, which comprises of the medical officer of that particular sub-district hospital, and then the LAC plus staff nurse and the pharmacist. If there is a general lab pharmacist at the hospital, then the pharmacist and the lab technician of the general hospital, or the standalone ICTC. So these form the particular team, and these people will undergo a 2-day training at those NACO identified training centers. And then also the tools that needs to be provided for those centers, along with the SOCH IDs, will be given by the concerned SACs. So how do you operationalize these centers? Then the CST officer of the SACs, nodal ART center in charge, along with the medical hospital superintendent and all the people, trained staff, and everyone will be there. And then once the hand-holding orientation is over, then the LAC place will be made operationalized within that particular period, once approvals have been given from the NACO. So which centers usually be taken up as to be scaled up is as an LAC plus is when you have more than 70 PLHV on ART, then those centers can be scaled up as an LAC plus centers, and the approvals will be given by NACO during the annual action plans. And then as I said, the feasibility visit again to upgrade from the LAC to LAC plus centers will be taken up by the concerned SACS officials, along in coordination with the DAPCOs, the technical experts, and the DISHA officials. And the SACs will appoint the staff nurses in this particular LAC plus centers once you get approval from the NACO. And then the trainings will be provided again with the concerned nodal ART centers or the RCs or the technical experts. And then the CST officials will also again volunteer the entire the LAC plus team. So these are all some of those steps that are involved in setting above LAC and LAC plus centers. So when we look at the functions of LAC and LAC, how is it different from the LAC plus centers? So when we talk about the functions of the LAC centers, so it mainly talks about the dispensation of the drugs and then refilling of the drugs, and then you provide the monitoring of the PLHAV on ART. You talk about the counseling on adherence, nutrition, and positive prevention. So the staff basically, we all know that the LAC plus LAC centers are there at the standalone ICTC center. So the counselor and the lab technician will actually be oriented on the standalone ICTCs. Apart from the standalone ICTC, they also be working for the LAC center. So the counselor and the lab technician will be oriented on on various activities of the ART, provision of the ART services for the PLHAV. And the treatment of the OI based on the capacity, usually if any patient has been found to be, has got any OIs, then usually in that particular hospital, if there is a medical officer, usually be referred there, or otherwise, if the higher the centers, then the nodal ART center, the patients will be referred to the nodal ART center. And then if there are any adverse effects also, the patients will be referred to the nodal ART centers. Tracking and tracing of the MIS and LFU cases will be done by the LAC staff on a regular basis. And TB, 4 symptom screening for the TB on each and every visit, and document the findings if there are any. And the routine, the psychosocial support for the PLHAV, and back referral to the nodal ART center as per the guidelines on a frequency of every 6 months. In case if they need an earlier referral also, that they can be done. And that depends. We'll look into scenarios where the patients have to be referred for the nodal ART centers. So when it comes to the LAC plus center, and we usually have a designated staff nurse placed on the SAC side, and which actually now as revised functions, apart from enrolling the PLHAV in HIV care and ART initiations who are clinically stable, and they also undergo a baseline investigations if the hospital facility general lab has got some baseline investigations. And apart from that, the CD4 testing through the linkage to the nodal ART center. So people, when there were situations when the ART initiations or has to be happen, or the CD4 testing has to happen, so there were certain questions that usually come up. So how do we actually link up the patients to the null ART center, and how do we actually, if the baseline investigations are not there? So these are some of the questions that were raised when we talk about the ART initiation at these centers. We'll see how those questions can be answered when we go in the next slides. And if there are any symptomatic clinically unstable patients, then the PLHO will be referred to the nodal ART center for the ART initiations. And just keep in mind to ensure that the ART initiations or modifications to the ART regimens will not be done by the LAC center. Okay, not anything will not be done at the LAC center or the LAC plus centers. As per the revised guidance, we can only talk about the initiation of the ART, but any point of that time, the modifications will not be done at any of these centers. So how do we set up? So this is the annexure rate of the operational guidelines. So the feasibility assessment that I said initially, how do we actually set up? So this is the assessment form that needs to be used by the visiting team, and then submitting it to the SACs, and from SACs to the NACO for the necessary further administrative approvals. So this is the feasibility assessment form, which is again there in the annexure 9 of your operational guidelines. So this is an assessment form where you actually have to fill it up before taking it up for scaling up the ART initiations at the LAC plus center. So this particular form needs to be, it's a mandate that this form has to be filled and submitted by the SACs to the NACO for further approvals for the ART initiations. And who are all has to be there, that we look into, because when we talk about the medical officer in the team, whether the medical officer is there, unless the medical officer is not, if the medical officer is not there, then we usually say the medical officer is not available, hence this particular LLS place is not feasible to start the ART initiations. If the medical officer is there and the other team is there, the medical officer, the staff nurse is there, you have a general pharmacy and you have an LT there, then this particular form has to be filled up with recommendation that this particular LAC plus can be scaled up as an ART, can be considered for the ART initiations at this particular site. So that this is the most important point that needs to be kept in mind when we do the feasibility assessment. So once the setup is done, and then we have looked at the functions of the LS and LSC plus centers. So now we look at what's the process of linking out of the patients from the nodal ART center to the LAC or LAC plus center. So first thing is the eligibility criteria. So what are those eligibility criteria? We'll look in the next slides. And the patient is eligible. And what's the role of the nodal ART center? How do we actually look at the patient being to be linked out to the LAC plus center? And how do we actually look at the supply of the ARV drugs? And then how do we ensure the recording and reporting from the LAC plus centers? So when we look at the eligibility criteria referral of the patients, when we look at the eligibility criteria, so any PLHAV or CLHV on any ART regimen and fulfilling. So previously, if you look at only if you look at the previous guidelines, the PLHAV were only to be linked out, and that two people PLHAV only on the first line regimen. Now the guideline has changed. The PLHAV or the CLHAV on any ART regimen, when fulfilling the stable criteria, can be linked out from the nodal ART center to the LAC or LAC plus center. So when we talk about the stable criteria, can you take a second and then put down what you mean by fulfilling the stable criteria of the patients? So quickly, can you put it in the chat box, please? So what do you mean by stable criteria? You can put in the chat box, please. What do you mean by stable criteria of the patients to link out to the LAC or LAC plus centers? More than 200 CD4 count. Okay. On ART for more than 6 months, no eyes, and viral load suppressed. Very good. No eyes, more than 6 months on ART. So how about children? How about CLHIV? What do you mean by stable CLHIV? You can actually see a few points there in the slide itself. So apart from that, continue for same ARV for 3 months, no dose change. Okay. If viral load history and the other ends is more than 95% and the CD4 is higher than 350, consecutive viral load target not detected. Okay. Okay. Thanks for those responses. So we'll just get into the stable criteria and see what exactly you mean by when you say stable adults and adolescent and stable children. So we'll discuss that in the coming slide. So stable criteria has to be fulfilled. Then patient has to be a resident closer to that LAC or LAC plus, and the patient has to give consent. Without the patient consent, the patient cannot be linked out. So that please make sure the consent form is given by the patient when you talk about linking out the patient. And then, as I said, stable patients on any ART regimen, whether it is the first line, second line, or third line. As I said, the previous guidelines used to say the PLHV only on the first line can be linked out. No other patients on any other regimen, second or third, will not be linked out. And the patients have to be on ART for more than 6 months. That's true. PLHV and TPT who have completed 3 months on TPT and belonging to stable criteria can also be linked out to the LAC, and the TPT drugs have to be transferred to the necessary LAC plus centers. And MMD, the patients, if at all they are availing MMD at the nodal ART centers, also can be provided MMD at the LAC plus centers. Okay, PLHV, poor adherence may be linked in LACs in order to enhance adherence and retention. This is again a revision compared to the previous guidelines. So with poor adherence, we were the old guidelines never used to say that no, they need to be linked out, but the guidelines have changed now. However, these people have to be followed up on a regular basis, so that though they are adherents, they are adhere to the treatment. And then how do they do that? They have to follow up monthly telephonic follow up by the ART centers. So we look at what exactly is the stable criteria. Adolescent more than 10 years, pale HIV shall be termed as stable if on ART for more than 6 months, no adverse effects, and no current illness or the OIs, okay, and no medical conditions which require regular monitoring, and the suppressed viral load less than 1000, CD4 count exceeding more than 200, and more than 95% adherence for the last consecutive 3 months. So this is the stable criteria for those adults and also for more than 10 years. Okay. Apart, and when you talk about the CLHIV for more than 2 years, fulfilling the stable criteria, again on ART, the children should be on ART for more than 6 months. Again, if they have underwent a recent viral load test and they are suppressed, okay, and then the adherence is more than 95%, ensure that adherence is more than 95% last 3 months, and there is no regimen change for at least minimum 3 months, okay, and no current clinical illness or the medical condition, including malnutrition, which requires further management. So these are the stable criteria that needs to be kept in mind when we talk about the stable criteria for the children and the adults. So these people can be considered to be linked out to the LAC plus centers. And then once once the ART once the patient is linked out, then the what documents need to be sent and what ART prescription has to be made. So once the patient is ready for the to be linked out to the ART center, link ART center, as I said, the consent has to be taken from the patient, and then provide information about LAC, which area, which particular area that LAC will be there near to his residence, and then you have to dispense 1 month of ART for that particular patient. So by the time he reaches and then he starts collecting the pills from next month, so you have to give 1 month of medicine for the patient, and then prescribe ART for 6 months. The rest we refill from the LAC. So only patient designated nodal ART shall be linked out to that attached LAC plus, LAC or LAC plus. We all know that you have a nodal ART center, and then your link ART and LAC plus attached to this only will be linked out to those particular LAC plus centers. Suppose the patient says, no, I want it from another LAC or LAC plus where the nodal ART is not attached to that particular ART center, then the particular counselor has to discuss with the medical officer of the designated nodal ART center and also with the designated nodal officer ART nodal ART medical of that the other ART center. And so we look at two different situations here. One is the LAC plus attached to this particular nodal ART center, and the patient requesting to be transferred out to the another ART center where the other LAC that he wants to move. So these things have to be kept in mind when we'll talk about link out and transfer out of the patients. Okay, and then again these transfer out, so these link outs have to be mentioned through the SOCH, and then the SOCH to which LAC the patient is being linked out. So these details have to be mentioned clearly in the SOCH and then also in the patient green book, and with the details of the link out address to which LAC the LAC plus the patient is being linked out, and also on the white card needs to be, and the white card needs to be maintained both at both ART sent at both the ART and the LAC plus center, clearly marking as the LAC copy and the ART center copy. And then the card has to be updated based on the information received from the nodal ART center, the LAC or the LAC plus center. And the nodal ART center shall report all the patients linked out on link ART centers in the monthly reporting format of that particular nodal ART center. And we look at what reporting formats have to be sent out from the link ART and the LAC plus centers as per the recent operational guidelines of NACO, and what format has to be sent to the nodal ART and how it has to be updated in the SOCH. Okay, so as I mentioned earlier, no LAC will not initiate or modify ART in any patient at any point of the time. This has to be kept in mind. The patient, whatever the changes that will be done, it will be done only at the nodal ART, not at the LAC center at any point of time. Okay, so how do we actually refer the patient on ART from LAC to the nodal ART center, on what conditions that we have to do? So when the patient is being linked out from the nodal ART to the LAC or LAC plus center, we call it as the link out. When the patient is referred back to the nodal ART center to the from LAC to the nodal ART center, we call it as the linked in of the patient. So patients will be linked in back to nodal ART centers in particular situations. One is routinely once in every 6 months for the repeat viral load testing, for the CD4 and for the comprehensive clinical review. And the patient has to be referred not at least prior 1 to 2 weeks prior before the ARV refill date, so that he can actually complete the viral load testings and then the routine investigations, whatever they are pending from the patient side, and then come back to the LAC plus centers. The other situation is the patient has got any OI or he has got diagnosed with the TB, or if there are any major adverse effects, then the patient has to be referred anytime that the patient, the LAC can refer anytime patient back to the nodal ART center. And pregnancy, in certain situations when the pregnant woman has needed, again, as we all know that they have to undergo a viral load test at 32 to 36 weeks of pregnancy, then they have to prepare for that particular viral load test, which is a mandate. And apart from that, for any other purposes, the pregnant ladies have to be referred. Again, they can link back to nodal ART center. And the unstable or unsuppressed PLHAV who have completed a step-up counseling and who has got more than 95% attendance for the 3 consecutive months, and no, they're unstable, then they can be linked back to nodal ART center. For the LAC outside the health facilities, PLHAV who are 4S positive are common minor wise. So as we know that the LAC centers have been scaled up. And now we have community-based LAC centers, we have the prison-based LAC centers, we have the OST-based LAC centers. So PLHAV who are outside the health facilities like these centers, so they can be linked back to the nodal ART center at any point of time. So what are the various documentations to be maintained are needed for the documents for the LinkedIn or the patient LinkedIn, as mentioned earlier, it has to be done through the SOCH. No need to maintain any. Previously, there used to be forms that LinkedIn forms have to be there, but now it will be done through the SOCH. The patient can be linked into the nodal ART center through the SOCH, and the nodal ART center will get a prompt whenever the pre-LHAV is linked in back to the nodal ART center. So the patient, the following details, the patient booklet, the green book with the details of the LinkedIn and the contact details of the ART center. So which center, which ART center the patient has to go back and report there, and then white card photocopy has to be sent back with the patient. So And then coming back to the nodal the activities, as we mentioned, that what exactly the nodal ART center has to be done routinely 6 monthly for the patients to be linked back who are linked in back to the nodal ART center is complete clinical evaluation of the patient. You have to do the 4S screening, the viral load testing, which is pending. The viral load testing has to be done. The CD4 count is pending, and then any other investigations as required for the patient. And then the drug refill shall be done from the ART center for the month when the patient is linked in. And if there are any changes or modifications needs to be done, it has to be done at the nodal ART center. If required, that will be done at the nodal ART center. And then whoever is undergoing a substitution or switch may be linked as soon as they are considered stable. And filling up the ART copy of the white card from the photocopy of the white card and the green book that needs to be done by the nodal ART center. In case for any reason the patient is retained at the nodal ART center, the information will be sent back to the LAC plus center, clearly mentioning the reasons why the patient is retained back at the ART center. So these some of the areas that the nodal ART centers has to follow up the patients every 6 months. So unless the coordination meetings usually happens from the nodal ART centers with the LAC plus centers, usually the field experience is the patients will not be linked in back to the nodal ART centers on a 6 monthly basis. And when we did an analysis at some of the states, it clearly showed that the most of the patients at the LAC plus centers never had undergone the baseline. I mean, the routine viral load testing they didn't undergo. They never had a viral load testing, and they had only the baseline CD4 count after which they never underwent another CD4 count or the routine investigations that were pending for a long time. As per the guidelines, the patient has to undergo either 6 monthly or 3 monthly or 12 monthly. So these investigations were never underwent by the patients. So these are some of those major operational gaps that were observed at the LAC plus centers. So what was the recommendation given for these centers was to have a regular coordination meeting at least on a monthly basis and look out the data where the PLHV have to undergo these investigations, and then sending out informations through the proper channels to the DAPQ and to the medical superintendent and the LAC plus centers to link in back these patients back to the nodal ART centers for the regular clinical evaluation of the nodal ART center. So these are some of the operational issues. Even the participants who are there in this particular session, if you go back and look back at your own ART center linked the LAC plus centers and analyze this particular data, you will clearly see that the patients who are accessing these particular centers, LAC plus centers, will have a major gap in undergoing the viral load testing or the CD4 counts or the routine investigation the patients are supposed to undergo as per the guidelines. So this is where the coordination needs to happen between the nodal ART center and the LAC plus centers. So we look at the SOP for the ART initiations at the LAC plus centers. Remind it clearly that it's the initiation will be only done at the LAC plus centers, and the two are the designated after the approvals of the NACO and SACs saying that okay, this particular LAC plus is now recognized to initiate the ART. And as I said, the feasibility assessment report has to be submitted. Annexure 9 that needs to be submitted from the SACs to NACO for any approval that these centers are going to start LAC plus the ART initiation at this particular LAC plus centers. Okay, so what is the process basically? So the LAC plus center, we all know that they have the standalone ICTC centers, the NACO approved the IC confirmatory testing centers. So once the patient is detected positive, so once the rapid ART initiation has come into the picture, so the patient has to be initiated on the same within 2 to 5 days of the ART being detected positive. So once the patient is detected positive, they has to be enrolled at the LAC plus center on the same day, and then screen for if there are any OIs using the NACO algorithm, and you have if the patient has any other comorbidity, including any other STIs, and then work on the WHO staging, and then the baseline investigations have to be done. The preparedness counseling will be given by the standard ICTC counselor or the staff nurse who are trained on giving the preparedness counseling. And then the documentation in the HIV care register, white card, and the green book has to be done. If the patient is symptomatic, he's got any OIs, then the patient will be referred to the nodal ART center. If the patient is not asymptomatic, then as per the preparedness counseling, after the address verification and identification of the family or the community support, and then CPT prophylaxis, we say when the CD4 is count, usually we have a report of that particular thing. And then the ART initiation can be done at the LAC Plus center, and then the follow-up has to be done for these particular patients who are initiated at the LAC Plus center every month on a month, and then assess for side effects on every visit and the adherence, and also reinforce the adherence part of it. And if there are any wise on every visit, the patients have to screen for the TB by the 4 symptom screening, and for any another, if there are any other wise, the patient have to be screened. And then also educate the patient on the positive prevention, and the reporting has to be done in the SOCH. And as I clearly mentioned, that these LAC Plus centers, the initiation will only be done if there is a medical officer available who is trained on the NACO-ART modules. As mentioned earlier, a 2-day training has to be done by the in the NACO designated training centers for all the these LAC Plus staff, which includes the medical officer, the staff nurse, the lab technician, the pharmacist, and the counselors of that particular LAC Plus center. So unless if this eligibility criteria is not met, then LAC Plus will not be permitted to initiate ART at these particular sites. And there might be scenarios where your medical officers keep changing when we talk about the area hospitals or the sub-district hospitals. In those cases, these particular staff who actually again come into those particular LAC Plus centers needs to be retrained again at the nodal ART center. Again, the same process will be followed. So without any training, these medical officers will not be eligible to initiate the ART for the patients being detected positive at the LAC Plus centers. So the nodal ART center will be issuing the HIV care number. One is whether you get it through the telephonically talking to the nodal ART center or through the search after registering the patient. So one copy of the white card will be maintained by the nodal ART center after issuing the HIV care of the registration number. So white card will be issued at the nodal ART center, and then the same white card will be maintained. The copy of that will be maintained at the LAC Plus center. In case the patient has become a miss or LFU, in the preparedness phase, it will also be done at the tracking and the tracing of the patient will also be done at the LAC Plus center. So what are the baseline investigations that the patient needs to undergo at the center is basically whatever the baseline investigations are available through the general health system, the patients have to undergo. So the patient will be referred to the baseline investigation by the staff nurse. So whatever the recommendations given by the medical officer. And then, as I said, the CD4 baseline testing sample will be collected on a prefix day and sent to the nodal asset. Some of the field experiences, the LAC Plus centers usually collect the CD4 samples, and then on a prefixed day, either weekly once or weekly twice, the samples will be sent to the nodal ART center for the baseline CD4 testing. And then the baseline investigations, whatever are available, based on that, the patients will be whether eligible for the ART initiations or not. That will be decided by the medical officer. And then after ensuring that there is there are no other comorbidities, then the ART initiations will be done at the LAC Plus center. So one thing that was the major gap was the linking of the CD4, the patient sample for the CD4 testing at the nodal ART center. So some of the states have this experience of having either the lab technician of the standalone ICTC carrying the samples on weekly once or weekly twice basis to the nodal ART center. The second option that was looked at was the general LT of that particular hospital with the approvals of the medical superintendent will be carrying the samples to the nodal ART center for the CD4 testing. This was one major gap that some of the states had. But apart from that, usually whatever the baseline investigations that were usually available even at any district hospital or the sub-district hospital can be are there without any issue there. So that was not any problem, but the major problem was with the CD4 count. So the PLHV who are initiated the ART, the LAC Plus centers, their preparedness and the rate of initiation will be recorded in the HIV care register. And as I said, the nodal ART center will be giving the HIV care register. Once the HIV nodal ART center gives, only the patient will be registered in the SOCH. So baseline investigations, whose investigations, if they are normal, will be called back to the LAC plus, and then or not normal will be called back to the LAC plus, and then the necessary adjustments will be made by the medical officer. Information related to the registration initiation of the PLH and LAC plus will be shared on a weekly basis with the nodal ART center through the SOCH. Only the nodal ART center shall issue the ART number after enrolling. It's not the LAC plus center, but the nodal ART center will be issuing the ART number. And then who are all initiated at LAC plus will be followed up on a monthly basis at the LAC for any monitoring purpose. And then the follow-up testing to the CD4 and viral load will be done at the nodal ART center during the routine 6 monthly visit of the patients. So I'm sorry. So PLHAV, who actually cannot be initiated at the LAC plus center, I'm sorry, the LAC plus center, for some reason that the patient has some OIs or some other comorbid conditions, then the patients will be referred back to nodal ART center. And then under the remarks column, the staff nurse will record the status in the HIV care register as referred to the nodal ART center. So when the patient is referred to the nodal ART center for management, the patient will be given the following documents: that the patient is being linked into the nodal ART center through SOCH, and the patient green book with the reasons for the linking along with the address and contact details of the ART center. So some situations with the patient, as we looked at the algorithm, if the patients are symptomatic, then usually they will not be initiated at the LAC plus center, but will be referred back to the nodal ART center. So in what conditions the patients will be referred? Usually, if there are any OIs, if there's the TB symptoms are there, and if the LAC plus thinks the patient cannot be managed, patient has some other comorbid conditions, and for routine laboratory purpose of CD4 and the viral load testings, and if there are any treatment failure conditions, the patients will be referred to nodal ART. If there are any adverse events or complications, patients with poor adherence and are difficult to manage at the LAC plus centers will be referred to the nodal ART centers. Okay. The nodal ART center should include all the LAC patients initiated on ART as well as on ART are the nodal for the reporting in the MPR. So these include all the patients. I think most of the data managers are aware that all the LAC plus patients or LAC patients are also reported as the nodal ART centers in the MPR. So what are the So what are the recording and reporting tools to be maintained at the LAC plus centers? So at the LAC, ART enrollment register, which is same as the ART enrollment register at the ART centers, which is to be filled by the counselor or the staff nurse. And the patient treatment record, which has to be updated during every visit, and sections 1 to 3 to be completed by the counselors, and sections 4 to 13 are to be completed by the LAC medical officer. And the green book has to be maintained at the LAC, the drug stock register and the drug dispensing registers to be maintained at the LAC centers. Apart from this, the HIV, at the LAC place, the HIV care registers has to be maintained, which is to be filled by the staff nurse. The CD4 sample transport register, which is again to be maintained at the standalone ICTC lab technician, and the HIV TB register in the line list to be generated, which is to be generated at the source. So these are the additional formats that needs to be maintained at the LAC plus center. So white card, as mentioned earlier, is to be maintained both at the nodal ART center and the LAC center, which clearly marking as the LAC center copy and the ART center copy. So the drugs availability, ideally the LAC or LAC plus center should have 3 months of stock available at the any point of time, depending on the number of patients that are there at these particular centers. So how do we actually calculate the quantity of the ARV drugs that are needed? So number of linked out PLHAV who are alive and are in miss from the nodal ART center into the 3 months of stock that is needed plus 1 month of buffer stock that needs to be calculated. For the LAC plus, apart from calculating the 3 months and 1 month of buffer stock, we also look at the number of positives being detected at that particular ART, and that particular stock will be maintained, which might be needed for the ART initiations for the newly detected positives at that particular LSC plus centers. So usually the 3 months of stock and 1 month of buffer stock needs to be maintained at the LAC or LSC plus centers. And if there are the PLHAV already on multi-month dispensations or expected to be on to be continued are expected to be initiated on multi-month dispensations. So this particular number has to be calculated again and then inform the nodal ART centers the amount of stock that is needed for these particular patients on multi-month dispensations. So mechanism of the drug transportation. So based on the calculation, usually the drugs are supplied to the nodal ART centers on a quarterly basis. As we said, 3 months of stock plus 1 month of buffer stock. So on a quarterly basis, in case if there is an if the drugs are required on an earlier basis, the drugs will be sent. So the pharmacist of the nodal ART center will be cross checking with the search and recommend the approval recommend for the approval by the SEM or MO in charge of the ART center. So how much drug has to be sent from the nodal ART, and based on the number of people on or the registered LAC or LAC plus centers, including the people who are on MMD, based on the calculations, again, including the number of people who might possibly be detected positive at these LAC plus centers. So that much of amount will be calculated by the pharmacist, and with the approvals of the SM or MO, that will be sent with the to the LAC or LAC plus centers. So usually the drug mechanism, whatever the NACO approved drug transportation mechanism is there, that will be followed from the nodal ART to the LAC plus centers, or the SACS approved the drug transportation mechanism that will be followed, okay, and which will be taken care by usually a courier agency or the supply chain management agency. The cost of the transportation will be borne as per the operational guidance will be as per that only. And then again, the TADA for the contractual staff involved in the drug transfer will be given as per the NACO and SACS guidelines. So reporting part of the drug stock, usually the nodal ART center will not deduct the total quantity of drugs transferred to link ART center in the monthly report. That will also include whatever the drug has been transported to the has been given to the LAC or LAC plus centers. So the drug deduction will actually be done of the dispensation to the LAC during the monthly report. Okay, how much of drug has been sent from LAC, LAC plus back to the nodal ART center in case if there is any stock that is pending over from at the LAC, LAC plus centers. And the pharmacist of the nodal ART center will be reporting stock in the search as soon as the stock is given to the LAC or LAC plus centers. And LAC staff will be updating the dispensation in Soch on a daily basis. Usually the staff, the LAC or LAC plus staff will be trained on Soch on filling up those Soch formats on how to dispense the drugs in the pharmacist module. And then the LAC in charge will physically verify the stock during every month and cross check with the Soch and the MPR and sign in the stock register. So monthly reports, when we talk about the Soch and the LAC monthly reports, so Soch logins will be created by the nodal ART to the each LAC plus centers, and the nodal ART center will conduct orientation mentoring for the LAC staff on Soch. And then the regular drug dispensation will be done by the pharmacist, the staff nurse, or the counselor in Soch on a daily basis. And in case if there are any issues in terms where the Soch entry is not possible, then the form B for LAC and form C for LAC plus has to be continued. And real-time data entry Soch will be shared with the nodal ART center and the LAC plus centers. So there are certain areas where there might be issues with in terms of the internet facility not available in the remote areas or the tribal areas. So some of the states have has practiced of communicating over phone to the nodal ART center regarding the drug dispensation on a daily basis, through the maybe over the phone or over using the social network, saying that this much of dispensation, the patient list they used to send. Again, the nodal ART center usually does the updation in the search on behalf of the LAC centers on a daily basis. So talking about the community ART refill groups, and this is a new concept which has been come up during the recent the revised guidelines. So community ART refill groups are basically a self-forming groups of stable PLHIV from the same geographical area. Okay, it could be a family unit or a positive network groups or a community groups or members of a specific key population. Okay, which is basically managed and facilitated by the the positive people themselves, or by the community people, or by the peers, or by the PLHF networks, or the care support centers, or CBOs, or the TA NGOs, or the link workers. So whoever wants to actually be form a community ART refill group, so these people can form a community ART refill groups. So there are certain procedures that needs to be followed when you say that no, this particular community of these key populations are from the CBOs or the TA NGOs have to be forming a community ART refill group. So certain procedures needs to be followed, which needs a basic formal registration at the ART centers, along with the details of the focal person and all the group members that are there in that particular community ART refill group. So some states have actually taken up the initiatives of forming community ART refill groups with within the TIs within the community by themselves from the key populations. And then there were people far off from places from the PLH network, PLHV groups. So these people have formed a community ART refill group, and we'll see what exactly are the SOP that are needed for the formation of the community ART refill groups. So the SOP is basically the identification of a group by the ARTC counselor has to be done, and then the focal person will be identified among that particular the car group. So for example, we have 10 people, they are there to form a community ART refill group. So one person on a rotation basis will come and collect the medicine from the ART center on a monthly basis, or once in 2 months, or once in 3 months he'll come in if there are people or an MMD or 2MD. So on that basis, those people, one particular representative will be coming and picking up the medicine from the ART center on behalf of the other community members. So each visit will be by the member. Each will be done 6 monthly basis on a rotation basis. So that will be done, and the counselor updates all the records in that particular car format that is maintained at the ART centers. So usually the community ART refill group staff member, the whoever volunteers or all the staff members who are all there will be oriented on basic things like looking for the 4S symptoms if there are any among the community ART refill groups, and if there are any, usually those community members will be referred back to the ART center to rule out any other OIs or any other comorbid conditions. So they will be, if the focal point person will be informing to the counselor about if there are any patients suffering from the 4S symptoms, and then they will report to the nodal ART centers for further follow. So as I said, these groups can be formed based on the need of the care, or the typology, or based on the geographical areas of that particular community. And the ART counselor and other staff of the ART centers will be providing the necessary support in forming these particular cards. So usually the number of the members vary depending on the local context, but ideally 10 to 30 members is what is recommended with the NACO guidelines, that if there are 10 to 30 members belonging to a particular geographical area, so they can form a community ART refill group. Okay. So as I said, these community ART refill groups will be registered at the ART center, and the patients who are all willing to be part of this particular call, the list of the people has to be submitted to the ART center, and they should be willing to disclose their status to each other, and should be fulfilling the criteria of stable fuel HIV. However, in case if there are on a case-to-case basis, if there are any non-adherent PL HIV, it is up to the medical officer discretion to consider this particular patient to be part of that community ART refill group, so that to ensure that the patient will be adhering to the medicine, and the long-term retention is taken care by the community ART refill group. So as I said, the focal person has to be identified, and then they will be coming and collecting the medicines on a regular basis. And also, as I said, they will be oriented on the providing adherence and 4 symptoms training for the community ART refill groups. And then if there are any OIs or comorbid conditions, usually they will be referred back to the ART centers for further management. And as I said, usually it depends on the community ART representation, the group, and then the focal point person, on how frequently one person should go and collect the the medicine, and if there are any further clinical evaluations, once in 6 months, every community ART refill group has to come to the ART center to undergo a complete clinical consultations and the necessary investigations. So I think we discussed this almost the CARC focal person and the responsibilities of the CARC focal person and the responsibility of the CARC members. So as I said, like on a 6 monthly basis, the patient has to come and collect the focal person will be coming and collecting the medicine, screening the patients for the 4 symptoms, and timely visit for the other committee members every 6 months for the complete clinical evaluation. And the CARC members is usually to ensure that they maintain a good adherence. And if there are any planned group meetings suggested by the focal person, they attend those regular group meetings. And clinical evaluation on a regular basis every 6 months. And in case of any symptoms, OIs or TB symptoms, immediately go to the nearest ART center. So this is the last slide. So to summarize, all the stable PLHV should be linked to the LAC based on the consent of the patient. And the nodal ART center is one of the most important criteria, that the nodal ART center should actually come out with a list of all the stable PLHV. And I think everyone is aware of the criteria of the stable PLHV, and also the package A, B, and C that were discussed, that were there in the operational guidelines also. So how do you actually categorize the patients into different packages, and then list out all the stable PLHIV, and then link out to the LAC based on the consent? This is one way to decongest the ART centers. So these patients who are linked out to the LAC will continue to the patients of the nodal ART centers, and the white card will be maintained both at the ART centers and the LAC plus centers. And screening and documentation of the TB symptoms on every visit has to be done by the LAC plus staff. And again, the dispensation on a daily basis has to be done by the LAC plus staff. And as I said, the initiations of the ART initiations at the designated LAC plus centers will be taken up unless can be taken up fulfilling all the criteria of availability of the HR, like I said, the medical officer, the staff nurse, the pharmacist, the counselor, and the LT. So ensuring the eligibility criteria and the training of the ART medical officer, he will not be eligible to initiate ART. So fulfilling this particular criteria, initiations can be taken up at the LAC plus centers. And if the patient is asymptomatic, okay, and stable, and ruling out any other major OS. So the training, mentoring, and monitoring of LACs will be done by the nodal ART centers. And apart from the training part of it, the nodal ART centers should take up the responsibility of monitoring and mentoring these centers at least once in a quarter, or on the regular need basis whenever the LAC plus staff needs any other support from the nodal ART center. Community ART refill groups, as we discussed, can be formed by any community-based networks, or the TI-based networks, or the CBOs, or the TNGOs, or the care support centers. And a focal person has to be there, and then the focal person will be responsible person to look after the community ART refill group, the other members. Ideally, 10 to 13 members must be there to form a community ART refill group. And the community ART refill group, whichever willing to form whichever community wants to form a car, they should be registered with the ART center, and prior informed again, registered at the center, and also inform the same to the district authorities and the state authorities. The LAC plus centers should ensure that all the PLHIV under care of LAC plus centers should undergo the routine viral load testing as per the timelines, and also the CD4 testing as per the timelines. And they should also ensure that all the PLHIV link availing service at the LAC plus centers should be screened for hepatitis B and C in coordination with the National Viral Hepatitis Control Program. So this has to be closely monitored by the nodal ART center. If the patients can be linked to nodal ART for the screening, or Hep B and Hep C, or if that Hep B screening can be arranged at the LAC plus centers for the benefit of the staff. But this has to be done again in coordination with NVHCP, then the district authorities, and also linking for the NCDs like diabetes, hypertension, cancer cervix, and the mental health in coordination with the NCDCL. As I said, again, this has to be done in coordination with the nodal ART center, the district authorities, and the state authorities. So the scale up of the services will be majorly focusing on, apart from the routine services LAC plus, the revised services will be the ART initiations at the designated LAC plus centers, as I said, meeting all the eligibility criteria, and then ensuring that all the patients has to undergo viral load testing, ensuring that the patients undergo CD4 testing as per the timelines, ensuring that the patients undergo the general lab investigations as per the timelines, screening for the hepatitis B and C in coordination with the NVHCP, and screening for the NCDs in coordination with the NCDCL. So in short, to summarize, these are the major scale-up initiatives to be taken up by the LAC plus centers in coordination with the nodal ART centers and the district and the state authorities. Thank you so much.
Thank you so much, sir. We can open up for question answers now. Participants have been given mic access. In case they have any questions, please feel free to unmute your mic, or you can put your questions in the chat box. Any questions? Yes, Chakravarti sir, you can unmute.
Yeah, good morning, sir. Sir, this is Dr. Chakravarti, TDCST AP SACS, Andhra Pradesh SACS.
Yeah, good afternoon, Dr. Chakravarti, sir.
Yeah, good afternoon, sir. Yeah, my question related to this LAC initiation, sir. Whoever got initiated at the LAC Plus Center, when should be having his first visit to the nodal ART center? Immediately after initiation or after 6 months? When should he be having his first visit at the nodal ART center?
See, nodal ART center, once you start initiating at the LAC plus center, ensuring that the criteria has to be met first, Dr. Chakravarti, because every LAC plus center is not supposed to initiate unless they meet the eligibility criteria. As I said, they have to undergo a feasibility assessment. Okay, they have to submit the report, and then they have to look at the HR medical officer is there. So this is one part of it. So once you ensure that this LAC plus is eligible for ART initiation, then the ART is initiated. Ensuring the patient is asymptomatic and stable, then the patient is initiated at the LAC plus center. So the routine visit, as you said, is one. The patient is stable, then the regular routine visit could be after 6 months, the patient has to undergo viral load testing.
Okay,
so
after
the first visit
initiation at the LAC plus, he can have his first visit, provided he is asymptomatic and stable.
Yes.
He can visit at the time of first viral load test at 6 months.
6 months, the first thing. The second thing is the patient, because we are looking at sample transportation for the CD4 testing. Okay. In case, if you want to say that sir, for some reason that the patient didn't undergo the baseline investigations at the LAC plus, so we have an issue, whatever the issue, it could be operational or technical issues. If the patient says, if the LAC plus staff says, so we are referring the patient, he is eligible for ART initiation here, and we have initiated him taking into consideration the rapid ART initiation, but we want to send him for the general lab and CD4. That could be his first visit, most probably. It depends. Okay. But taking consideration into everything, the stable criteria and the baseline investigations have happened. So the patient sample transportation has been done for the CD4 testing. Then the first visit could be after 6 months, where he has to undergo the routine viral load testing after 6 months of ART.
Okay, sir. Thank you. Thank you very much.
Thank you, Dr. Chakravarti.
Any more questions? Please feel free to unmute your mic.
So I think the important question is, I think Dr. Chakravarti asked about the ART initiations and when the first visit has to be done. So I think the CARG is one of the most important area where I think the participants should actually focus on. So how do we start? Because this is a part of your nodal ART center. It's not done at the LAC plus center. It has to be done only at the nodal ART center. CARG, in case if LAC plus, again, as I said, if LAC plus wants to form a CARG at that particular areas where, as I said, minimum 10 to 30 members are there, then the same procedures will be followed, that this has to be intimated through the district authorities and the state authorities, whether unless based on their approvals, they cannot be at that level, if they cannot start usually. It has to go through again to the nodal ART center.
Okay, sir.
And I think AP has done an excellent job in terms of the TI CARC models. I think 10 or 12 centers, the TIs are actually running the TI CARC model for the key populations.
Yes, we did, sir. Actually, this was the doubt
Yes, yes.
been
Then
asked
in
by
that one of
some nodal ART centers where we have initiated this LAC a plus ART initiations. They were having doubts. I wanted to clear it so that if I get
yes,
it
yes.
from you, then I
Yeah,
will be communicating the same with my ART members.
sure, sure. It
Thank you, sir.
depends
Thank you.
on the stable and unstable criteria for the patient to be referred to nodal ART.
Sure, sir. Sure.
Yeah. Any other
Any,
questions, Sweta?
so nothing in the chat box. Any questions from the participants? Please feel free to unmute your mic. The mic icon is on the left-hand side bottom of your screen. So I
Okay.
don't think there are any questions. Thank you so much for
No
facilitating
question.
this important session. Thank you, Dr.
Okay.
Bhavani, sir, for joining
So
us and for your opening remarks.
let me ask the participants, how many of the states? 1 second,
Yes,
Swetaji.
sir. Yes, sir.
Swetaji, 1 second.
Ji, sir.
No, no, I am just asking if any of the participants here in the states they have started any of these models of CARC or no, the ART initiation of the LAC plus. Any of the states have done that, so they can just respond yes or no. Apart from AP and Telangana, if they have started any CARC models or LAC initiations at ART initiations at LAC plus. Any states? No. Or anyone want to start at least? Any states? No car. Which state, Dr. Alkaj? Gujarat. Okay. At least ART initiations at the LAC plus the state has started. Gujarat mein. No. No car. Tamil Nadu. Oh, okay. At least Dr. Mary, any LAC plus ART initiations? Tamil Nadu. Only at Disha LAC plus. At least, yeah, good. At least there's one center, no, where the ART initiations started at LAC plus. And hopefully, I said all the eligibility criteria are met for these LAC plus centers. Okay. Any other questions? Or see, these are the part of the national guidelines. So I think the states can actually look at the operational guidelines and take up those the initiatives which are actually be beneficial for the community. So you're actually taking the services to the doorsteps of the community. So I think states actually can go through the operational guidelines and then discuss with the concerned authorities of coming up with these models at your states. Pondicherry Jipmer, yes, anything from Pondicherry Jipmer? You can actually speak. The mic is open for all. No questions? Yeah, Swetaji, over to you. Thank you so much, sir, Dr. Bhavani sir and Dr. Purnima. Over to you, Swetaji.
Thank you so much, sir. Dr. Purnima ma'am, any closing remarks from NACO?
Thank you, Shweta, and thank you, Dr. Ravi, for this wonderful session. I think he's already clarified all the important uh, areas around LAC and LAC plus. I would just like to reiterate that when we are thinking of initiating ART at the LAC plus, then we should also look into who is posted at the LAC plus. Are they trained for initiation of ART? And the individual, the PLHIV who is initiated on ART at the LAC plus, are very critically examined, clinically examined at the LAC Plus Center. So that needs to be really a good mechanism has to be followed when you're proposing initiation of ART from the LAC Plus centers. So that's all from my side. And if there are, I think there are no more questions. So probably you can close the session. Over to you, Shweta. Thank you.
Yeah, thank you. Thank you so
Thank
much,
you, Dr.
ma'am. Thank you once again, Dr. Bhavani sir, for joining us today for the opening remarks. We thank all the participants for patient listening. We'll conclude the session now.
Thank you so much.
Thank
Thank
you,
you,
sir.
Kiran.
Thank you, everyone.
Thank you, ma'am.
Thank you, Dr.